you very much. My name is Marc Carrier. I'm a professor of medicine at the University of Ottawa, and today we'll be talking about a very important, clinically relevant topic, but a topic that doesn't have a whole lot of awareness amongst healthcare providers: cancer-associated thrombosis. It has important consequences for cancer patients, and it leads to a lot of increased morbidity and mortality. So today we're going to try to discuss the topic together. So don't get me wrong, when we talk about cancer-associated thrombosis, we mean the lower limb deep vein thrombosis, or sometimes when it embolizes, it becomes a pulmonary embolism. That's not very common in the general population. We're talking about 1 in 1,000 or so. But as soon as you have a diagnosis of cancer, as soon as that cancer patient is starting chemotherapy, it's no longer 1 in 1,000, we're talking about 1 in 200. And as you know, the cancer journey is complex, and cancer patients often have to have central venous catheter being inserted for chemotherapy deliverance. They need to be admitted to hospital for complication of their cancer treatment. They need biopsies, surgeries. All of these things are additional risk factors that can increase the risk of having a symptomatic cancer-associated thrombosis. So when you take the whole cancer journey from the time of diagnosis until the end of life, we're not even talking about 1 in 200, we're really talking about 1 in 20. So that's something that is very, very common. And this is important because patients with cancer-associated thrombosis have important consequences. They may have chronic lower limb swelling if they have post-phlebitic syndrome, dull, achy pain that is itchy sometime. They may have post-PE syndrome, so problems with exercise capacity, shortness of breath when they're mobilizing, when they're doing exercise. All of these things is leading to decrease in their quality of life and also increase their mortality, decreasing their survival. Thromboembolism is the second leading cause of death among cancer patients. That's after cancer progression, equal with infection. This is terrible. You go today to the cancer center, you go into the waiting room, you ask cancer patients waiting to see their doctors, their nurses, or their healthcare providers, do you know what the signs and symptoms of infections are? They know about febrile neutropenia. They know that if they feel unwell, they need to take their temperature, and if they have fever, then they need to seek medical attention. They need to see their nurses, their pharmacists, their doctors. They need to go to the emergency room. But if you ask the same patients, do you know what the signs and symptoms of deep vein thrombosis or pulmonary embolisms are? None of them would know. And that leads to decreased diagnosis or a delay in diagnosis and delay initiating anticoagulation treatment. And that leads to more chances of having chronic morbidity and decreased quality of life and increased chances of dying from the underlying disease. So it's important to create awareness to patients, but also to other healthcare workers so that we can all educate our patient about signs and symptoms of DVTs and PEs so that they can seek medical attention and treat it with appropriate anticoagulation. Now the next question is, what if they have a cancer-associated thrombosis? What type of anticoagulation? Well, you know, over the years, if we go back 15, 20, 30 years, we were using a vitamin K antagonist or warfarin. But warfarin has a lot of drug-to-drug interaction, drug-to-food interaction. It needs frequent monitoring, so it has a very narrow therapeutic index, so it's really hard to control in cancer patients, so it's hard to do. In the early 2000s, a parenteral or subcutaneous type of blood thinner was checked against vitamin K antagonist, the low molecular weight heparin, has been shown to be maybe something that we could consider. And even now, if we go into the future, or if we look at right now, there's direct oral anticoagulants that are available that have been shown outside of cancer to be effective to treat deep vein thrombosis and pulmonary embolism, but we're not sure yet what to do in the setting of cancer-associated thrombosis, and we'll look at that. We mentioned that low molecular weight heparin is now or has been the standard of care for a decade or so. And the reason for that is because there's a number of randomized control trials that have compared low molecular weight heparin to warfarin or vitamin K antagonists, and has shown that when patients are treated with low molecular weight heparin, you decrease the risk of having a recurrent VT by about 50% without increasing the risk of major bleeding at all. Therefore, it makes sense, right? Because parenteral drug, I agree, but it has no drug-to-drug interaction, no fluctuation, and provides better efficacy compared to vitamin K antagonist. But it remains that it is an injection, and people have to learn how to do subcutaneous injection and do daily injections. So the question arises, well, are patients being compliant with low-molecular heparin over time, and are they using it as long as their doctor, nurses, or pharmacists are telling them to do so? And there's data coming from the US that, understandably, when patients are on a parenteral or subcutaneous blood thinner, they're less likely to be compliant or to take the treatment long-term over time compared to vitamin K antagonists or the directal anticoagulants, for example. So it begs the question, are the directal anticoagulants something that we could use for cancer-associated thrombosis? Because as I mentioned, they've been looked upon compared to vitamin K antagonists in non-cancer patients, and they're available in Canada for treatment and prevention of venous thrombosis in this patient population. There's a lot of qualitative studies that have looked at directal anticoagulants in the setting of cancer-associated thrombosis, and they seem to show that the directal anticoagulants were associated with slightly lower risk of recurrence, similar risk of bleeding. But really, in order to change practice, you need to have randomized control trials that are comparing the directal anticoagulants to low-molecular heparin. And over the past year, there's 3 trials that have been presented and published comparing different directal anticoagulants to low-molecular heparin. And I'll talk a lot about the first one, the opioid VTE cancer, because it's the biggest trial, and it's the one that was better conducted. Over 1,000 patients with cancer-associated thrombosis. It was a randomized, multinational, multi-center trial, non-inferiority design, and patients were randomized to have 5 days of low-molecular heparin followed by a directal anticoagulant, edoxaban, 60 milligrams PO daily for at least 6 months and up to 12 months, or the standard of care right now, which is dalteparin, low-molecular heparin, the usual unit, so 200 units per kilogram per day for the first month and 150 units per kilogram per day thereafter, again, for at least 6 months and up to 12 months. Now, when we look at this, remember this is a non-inferiority trial design. What we can see is that after 12 months, the 2 treatment regimens are very similar, and edoxaban was non-inferior to low-molecular heparin for the primary outcome of the first event of a recurrent VTE or first episode of major bleeding. The hazard ratio was 0.97. The P was non-inferiority was significant for non-inferiority, and that leads to the conclusion that that particular directal anticoagulant was non-inferior to low-molecular heparin. But as a clinician, that's all fine and good, but at the end of the day, you want to have a look at the different components, right? You want to see, is the directal anticoagulant as effective? Is it as safe compared to low-molecular heparin? So when you look at the different component, when you look at the risk of recurrent VTE, patients that receive edoxaban were less likely to have recurrent VTE compared to those that received low-molecular heparin. The hazard ratio of 0.7, and that was not statistically significant. But you can imagine that there was an increase in the risk of major bleeding, and the hazard ratio was 1.77, and that was statistically significant. So as clinician, you're already wondering, well, maybe some of the directal anticoagulant I could use for cancer-associated thrombosis, but Marc, you're saying there's an increased risk of major bleeding. Can you predict the site of bleeding and what type of patient? And then when you look at the major bleeding and you look at the 2 groups, patients that received an oral anticoagulants or low-molecular heparin, what we see first is when we look at the severity of bleeding, there's no difference between the 2 groups. There's no big difference between patients that between patients that receive edoxaban or low-molecular heparin based on fatal bleeding or intracranial bleeding. The real difference between the 2 groups was patients that received edoxaban were more likely to have upper GI bleeding, and a large majority of these patients had GI tumors. So at the end of the day, when you put all that together, some clinicians are wondering, well, Marc, should I just use low-molecular heparin for all my cancer-associated thrombosis? Can I switch and use a DOAC for all my patients? Well, the answer is probably right in the middle, and we need to tailor anticoagulation accordingly. So what do we mean by tailoring anticoagulation accordingly? Well, the first thing is to look at the risk of bleeding. We just mentioned that certain tumor types might be at higher risk of having bleeding consequences or complication. GI tumors, for example, And another trial that compared direct oral anticoagulants to low molecular weight heparin has shown that those that received the direct oral anticoagulant, in that particular case rivaroxaban, had a higher risk of having clinically relevant non-major bleeding. So if you have these patients, maybe you should consider maybe using a low molecular weight heparin for these particular patients. So risk of bleeding, is there any drug-to-drug interaction? Because the DOACs do have some drug-to-drug interaction, but the most important thing is patient's preference. Patients, when they come to our clinic, they don't see themselves as being a clot patient. They see themselves as being a cancer patient first. So the first thing in their mind is, Marc, do whatever. I know I need to start blood thinners because I have a clot, but please don't start any blood thinners that has drug-to-drug interaction that will complicate chemotherapy, that will delay my surgery, for example. That's the first thing on their mind. Afterwards, of course, they'll think about efficacy and safety. And then lastly, it'll be the route of administration. Is it parenteral, subcutaneous, or oral? And the reason why I say that is because we may switch, or we may want to start some patients on the parenteral agents versus others on an oral agent, and that might change down the road as well. It will depend what's going on during their cancer journey. So you need to be mindful of that and explain that, and the patient will accept it. And dependent if we're doing the right things, or making sure there's no delays in their chemotherapy, that we're using an effective and a safe agent, that's the most important thing. So what I wanted to cover was really these three things. The first thing is cancer-associated thrombosis is very, very frequent in our patient population. It's associated with increased risk of complication, increased risk of morbidity, increased risk of mortality, so it deserves awareness. It deserves for the patient at high risk to have a 2-minute conversation about the signs and symptoms. Some of these patients will have a clot. What type of blood thinners to start is now a little bit different because we have new tools in our arsenal toolbox for cancer-associated thrombosis treatment. Some patients may deserve to be on direct oral anticoagulants, while others deserve to be on low molecular weight heparin. That might go back and forth during the cancer journey. But there's more options available, and hopefully that will help us to change standard of care and make patient clinical care better overall. Thank you.